Well, today as I munch my breakfast and look out the window at next door's cat that's come to see me, it's an important day in a way. It's Thursday, 8th of October 2020. It's exactly 30 years since I first went into heart hospital for my Wolff Parkinson White syndrome, which turned out to be Wolff Parkinson White syndrome with atrial fibrillation, for which I was immediately the next day put on these tablets, which used to be made by Riker, actually 3M Riker in Loughborough, and generically are known as FleckEyed acetate tablets, which are a class 1C antiarrhythmic drug. You see there it is. Alright, so I'm going to discuss going to Groby Road Hospital, Leicester, which is now Glenfield Hospital, Leicester, back in 1990, and what happened about my electrophysiological study. I'm going to talk about Wolff Parkinson White syndrome because that's what I've got, and I shall talk in a few videos on the mechanisms, symptoms, therapies, and the impacts 30 years later. 30 years later gives me plenty of time to discuss the impacts and to find out what they were, and maybe advice. Okay, so Wolff Parkinson White syndrome is caused by what's called an accessory pathway, or a bypass tract, or a bundle of Kent in the heart. You've got your normal heartbeat, which comes from your sinus node, and it goes down through the AV node, and it goes through the His-Purkinje system, and it makes your heart beat in an orderly way. However, if you have this accessory pathway, this extra bundle of nerves, this should basically all be insulating between the atria here, right atrium, left atrium, right ventricle, left ventricle, because you're looking from the front on these diagrams of the heart. This shouldn't be there, okay? But it conducts, and it conducts faster than this system, which kind of has a timing mechanism on it to limit the heart rate, okay? Which is part of your nervous system, part of your natural makeup to decide what your heart rate is going to be, whether you're exercising, whether you're in fight or flight, or whether you're in rest and digest or whatever, okay? So your sinus node, I guess this is dictated by your brain and by the speed at which this beats, okay, and the speed at which your heart beats is dictated by your nervous system. This thing here is a law unto itself, and sometimes it can conduct backwards, sometimes it conducts forwards. That's antigrade and retrograde. Retrograde is backwards, antigrade is forwards. Sometimes it's bipolar, it can conduct either way. If it conducts forwards, you have Wolff Parkinson White syndrome. And what happens is on your ECG, you get the P wave, which is the atria beating. Then there's a delay because of this AV node and how long it takes the signal to get down here. Then you get an orderly, sharp R wave. It's called a QRS complex, actually, which is your main heartbeat, which pumps the blood around you. And then you get the T wave, which is the kind of relaxation or the resetting of the heart muscle afterwards. Well, if you have this accessory pathway, what happens is the impulse goes down here a little bit quicker than it does down here, and you get what's called pre-excitation, which I didn't write on here for some strange reason, and you get a bit of your heart beats before the rest of it, and then the rest of it beats, and you get a thing called a delta wave because it's shaped like a delta, like a Greek letter delta. It's a triangle, basically, and it sort of smudges out your heartbeat. You still get the P and the QR and the S and the T. The Q is this point here, actually. But anyway, it also means you get a short interval between the P and the R, or between the start of the R, which is really this bit here, okay? this interval shortens. So you have this delta wave plus this short interval here. That tells a cardiologist or anybody who has any sense that you've got Wolff Parkinson White syndrome, and an ECG should be enough to do that. What can happen though is that signals can come down here in a more disorderly manner, and they can come up in a disorderly manner as well. And what can happen is that you can have the normal heartbeat and you can have a re-entry into the atria through this accessory pathway and get what's called a superventricular tachycardia, or reciprocating tachycardia, because it's going between the atria and the ventricles. This is independent of any impulse that's coming to your normal mechanism, okay? So this is going to be pretty much a fixed rate depending on how long this pathway is. You can, and that's called an orthodromic, that's the normal way. You can also actually get an antidromic one. I didn't know about this until quite recently, where it goes down this pathway and it comes up, actually comes up the normal pathway, up the centre, okay? Which gives you a wider complex, a more a nastier type of tachycardia actually, but it's still really a superventricular tachycardia. Or if you have atrial fibrillation, you can get, oh heavens above, 400 plus atrial beats per minute coming down here, or trying to come down here. You can get an almost unlimited heart rate in atrial fibrillation. It can be very, very fast. And the only thing that determines how fast that is really how short or long this pathway is and how long it takes it to reset. Okay, how long it takes it to reset so that it can accept another impulse. That can give you ventricular rates of 300, 350 even, which are extremely dangerous. With me, my average ventricular rate was measured at 190, maximum was measured at 250. Somewhere between 220 and 240 is where the threshold says it starts to get dangerous. Okay, so basically what I'm going to do is I'm going to discuss all of this on this channel. Okay, I'm going to discuss the mechanism. I'll do it in much more detail. Discuss the drugs that you have to take for it, and to discuss the fact that you can sometimes at least now have this pathway ablated. I'm also going to discuss what's called the electrophysiological study, where they stick some catheters up one of the veins in your leg or in your arm or both and stimulate the heart from inside to find out where this pathway is and to find out whether the rhythms you're getting are dangerous. So I'm going to discuss all of that on this channel in several videos, but the thing that's really got me going on this is the fact that, of course, it's the 30th anniversary of when I first went into heart hospital. Tomorrow will be the 30th anniversary of when I had my electrophysiological study, which was actually rather torturous and lasted for 3.5 hours plus, and was really then, with the technology they had, a really rather very unpleasant experience, because they actually managed to induce a lot of arrhythmias in me, mostly this kind of arrhythmia, which is rather nasty. So I was then immediately told to go on these drugs, okay, and tomorrow it will be 30 years, if I live that long, since I first took my dose. So I took my very first dose of this medication. So on that note, it's coming up to 10 minutes, I'm going to eat my reasonably healthy breakfast. And I hope to make another video tomorrow on the anniversary of my electrophysiological study and talk about this in more detail, and then later talk about the different aspects of this, especially mechanism, symptoms, therapies, impacts and advice. And probably a lot of this is going to apply to people who have other heart rhythm difficulties, because back in 1990 this was a much neglected subject. No GP I knew anything about it. They didn't even know the existence, which was absolutely shocking and disgusting in my view, because it was discovered in the 30s originally, of this syndrome and of these arrhythmias. So you wouldn't really get treated for it. So if you had this and you died, it was kind of tough. But now there are treatments, and a lot of people know about it. Ambulance drivers know about it, paramedics know about it, and there are therapies. So on that note, I'm going to say ta-ta for now, and I hope you watch me tomorrow.